is a big topic. It's a topic that makes headlines pretty much minute by minute. So what we'll have to do today is really think about how we're going to tackle this, and first and foremost by education. So really understanding the diseases associated with coronavirus. Coronavirus is not a new virus, as we'll talk about that a little bit. And then really understanding the current COVID-19 outbreak and key points related to transmission. Really familiar with the management of patient with COVID-19 infection. This is going to be a presentation, obviously, that's going to be current today. After this presentation, there are probably going to be an influx of changes on the CDC website, so that I can't control. So really, this is a snapshot of what we know right now. Okay? So the one thing that's important here is this slide. Okay, this slide is probably going to be the most important. This is why I actually decided to do this. This is why I'm here. Okay, so this is Bob. Okay, Bob is not panicking. Bob listens to scientists instead of news media. Bob is not buying items in bulk. Bob washes his hands all year long because he's not gross and knows basic hygiene. Be like Bob. This is going to be very important today, that all of us in this room, especially us, we model after Bob. Because there's a lot of frenzy out there. And if we embark in that frenzy ourselves, our patients will be lost. And that's where we have to be very careful about how we conduct ourselves. And it may be simple, but Bob is our role model. Okay? Basic facts. Coronavirus is not new at all. This has been for decades. Coronavirus is everywhere. Coronavirus is in the environment. Okay? It's a big family of viruses, and there's 4 genera: alpha, beta, gamma, delta. The ones that are most important for human diseases are alpha and beta. There's a lot of diseases in the animal kingdom as well besides humans, and some infect our animals, but not for beta. Beta is mostly for humans. Okay? So this is why it's called coronavirus. That's what it looks like on electron microscope as a corona, like the sun. Okay? So this is why it's named. Again, guys, this is not a new virus. This has been in circulation since the 70s. Okay? So where and when? It's widespread. It's wherever we look, it's detected. Infection can occur at any time of the year, most commonly in winter. All right? So accounts for about 5 to 10% of all acute URIs in adults. This is not a new virus. Okay? It is also only 5 to 10% of all URI in adults. That would include influenza. Okay? So it is not commonly seen, but it is out there. So when we do a rapid pathogen panel and we see coronavirus, it is the coronavirus that is not the COVID-19. And it's been out there forever. Okay? We know that the peak season and symptoms can be strain specific. So different strains of alpha and beta can have different times of the year and different severity of illness. Strains actually may be coming back every 2 years and less commonly seen than others like rhinovirus, which is a common cold virus, influenza, or RSV. Co-infections are common, so when we do in children, especially children, when we do this rapid panel, we see 1, 2, or 3 different viruses. So co-infection with coronavirus is common. And look at this. It travels into the lower respiratory tract, 1.5 per 1,000. That's mainly in children. So a lot of studies on coronavirus are in children. Okay? So 1.5 per 1,000 that actually causes pneumonia and more severe infection. Transmission, large droplet or direct contact. So what we mean by that, this is a famous picture when somebody sneezes or coughs, you can see the plume of droplets, okay? This is what carries the active virus that will go, unfortunately, on somebody else's face or other parts of the body, and also on different environmental surfaces, okay? So we know that we gain rapid immunity, so we protect it, but it wanes. And also that virus can mutate like any other viruses. Viruses can mutate very easily, okay? And we do have viral shedding, meaning some viruses, before we are sick, we shed them. When we're sick, we shed them a lot. That's why it's infectious. And then after that, after the illness has passed, sometimes we can shed it for 2 to 3 weeks. Hence, for the COVID-19, why we talk about 2 weeks of isolation or quarantine. And we'll talk about that in a little bit. Okay, clinical manifestations, influenza-like illness. So it tells you it's like influenza. Okay, so URI, rhinorrhea, nasal congestion, serious otitis media. So commonly seen in the internist's office. I mean, we see that constantly, especially in flu season. So if it's a flu-like illness, it's really hard to differentiate the flu from coronavirus and other viruses. It can create pneumonia, so it's a common cause of respiratory pneumonia, and it can lead to severe ARDS, okay? So severe respiratory infection, including ARDS. And it's third and fourth most common between all these viruses, including influenza and rhinovirus, also metapneumovirus and parainfluenza that are in circulation pretty much every year. So all these viruses are all in the panel that we test by PCR, the nasopharyngeal swab that we do. Okay? It can cause acute exacerbation of COPD, and that becomes important outbreaks. And it also can infect long-term care facilities, populations. So this is why the elderly is very fragile with that. So how do we diagnose coronavirus? Clinical diagnosis. I like that when we say that because I just told you it's an influenza-like illness and we can't differentiate. So we always say clinical. But in the real sense of things, we can't say that this is a viral URI and that's it. Okay? So if you want to be more specific, then you have to test by PCR. The reason we test by PCR is that it's really hard to grow. Okay, so all these viruses are, including influenza, are hard to grow. So we really have to do a nasopharyngeal swab, and what I mean by that is the posterior pharynx. So this is the swab where you really have to go really deep. Patients don't like it, they cry, they do something else. They tell your name about once you hit something, you continue a little bit deeper, you scratch, okay, and then you come out. Okay, not very pleasant, but it has to be done. This is different than intravenous for MRSA. Okay, so you just don't swab quickly and be done. So sampling is very important because if you have operator-dependent errors, then that becomes somewhat of a skewed result. So treatment and prevention, and this is another very important slide. This is true for coronavirus and COVID-19. There's no treatment. And I know you're going to hear, wait a minute, they talked about this, and this. I understand all this. There is no active FDA-proven treatment. There is no role in steroids. The reason about steroids is one of its cousins called SARS. Actually, steroids were really a bad thing to do with patients. They actually prolong the viral shedding. All right? It is what we call supportive care. That means that supportive care really means, we treat the symptoms. And we treat if people have difficulty with, hypoxemia or respiratory failure, we treat accordingly, but we don't treat specifically the virus. Hand washing is by far the most important thing to do, okay? So, and it's water and soap, and if you use alcohol, it has to be more than 60%. This goes the same way for disinfectant that are used for this, bleach will work. Chlorhexidine, be careful, only if you have alcohol on top of it. Anyway, I'm not gonna go into the details of the disinfectant. That's not the role of this talk. But really, there's a list that you can get in the references right here. But really, hand washing, right? So that would include when you put on a mask. The outside of a mask is contaminated by definition. So if you touch it with your hands and you touch something else, then you just spray it. All right, so hand washing, and we're talking about water and soap. And it doesn't have to be hot water, so that has to be at least 20 seconds. Okay? All right. So in the last 15 years, we had 2 outbreaks of 2 different coronaviruses: SARS in the early 2000s and MERS in 2012 or so. And both were the same family. In fact, this virus right now is much more related to SARS than MERS, but it's closely related. So it does not quite behave the same way, but it is related. So SARS and MERS were actually a much more severe infection than COVID-19 that we know thus far, okay? So, and SARS originated from China, just like COVID-19, we'll talk about that. And it really spread around 29 countries, and there was about 9,000 cases. And mortality rate was pretty high, about 10%. MERS really originated in the Arabian Peninsula, and it's still a non-contained infection, by the way. There's still transmission of MERS to this day. Well, MERS was really, really severe. Mortality, a third of patients would die. Really quick ARDS like So here we go. Wuhan, China. This is where it all started, okay? And this is where we're going to walk through from China to St. Louis, okay? So let's first start with Wuhan, China. December 26th, this is where it all started. 3 cases of pneumonia, and mostly elderly, mostly with pulmonary disease, but really unusual, very quick ARDS type. Okay, started the URI. Now, mind you, the population of Wuhan is 11 million. Okay, so just put that in perspective. All right, so start with 3 patients. Okay, about a week later, they had an outbreak already. Okay, and they had several patients from around town, and they could figure it out. Well, they did it in about 10 days. So they figured out that it was a virus. They figured out it was a coronavirus. They actually sequenced it, and they realized that it was just like SARS. So it's the same virus, so almost. Okay? And they actually isolated first from a BAL, which is quite extraordinary. But anyway. 1 week later, first case in Thailand. Then in Japan. By mid-end January, Wuhan has about 50,000, 40,000 cases. They're in lockdown. They basically said this is the only way to control it. We're going to basically kind of just lock that down. All right? It will work. It actually worked. Okay? So, obviously, around the world, cases start popping. By the end of January, WHO says, wait a minute, this is an international problem, and this is a health emergency. Okay? And at that time, people were like, well, WHO was like freaking out here. Okay? So, but they were not, because as of yesterday, right, you guys heard this is a worldwide pandemic, right? So I'm digressing a little bit, but we'll go back to that. And this is the original BAL, where they isolated the virus and really worked very efficiently with virologists to really isolate and categorize this new virus. Okay? They called it SARS-CoV-2 because it's related to SARS, and the disease itself is called COVID-19. Okay, this is a busy slide, okay? So this is really in China, in Wuhan. This is every day here, and this is the number of cases, okay? And it goes, 4,000 or so on the y-axis, okay? And on the bottom, it's different things that happened along the way. All right, so obviously, small number of cases, really we think the cluster started in December 26, and then small number of cases. Within that time, they realized they had a problem, they isolated, they had a test, and after this presentation came the diagnosis. This is why there's two curves, okay? So, bell-shaped curve of really the number of cases, then afterwards confirmed cases by diagnosis, right? And look, it's going down, right? That's because really in that period of time, they decided to go on lockdown. Okay. We have to understand that the disease spectrum is evolving. We have to have guidance from the WHO and the CDC, that these are going to be their guidance, okay? Every day. Within the day, it changes, okay? So, I don't pretend I will have all the answers here today, okay? Because I won't, right? So, significant changes occur in management of patients under investigation, all right? So, meaning, when we decide this patient may have COVID-19, the definition of should we test, should we do something, will change with time. It already has changed multiple times, creating sometimes confusion among healthcare workers. All right, so it's a beta coronavirus. We know it's related to SARS. The sequence is the same here that it was in China. So we know it's the same single strain of virus. We most likely think that it was animal to person first, and there was that question of the fish market or whatever in Wuhan that started the debate, but then it was never clinically proven. For sure, it was followed by person-to-person transmission. So this is something that we humans transmit to one another, 100%, okay? That doesn't mean that one is infected, the other one right next to us will become infected, and we'll talk about that a little bit, okay? But for sure, it is person-to-person transmission. Okay. This is the worldwide global cases. In beige here, these are the cases in China. And in pink here, this is excluding China. Okay? So obviously, 98% or something of the cases are in China, were in China. And it went really fast, and because of the lockdown, is actually plateauing. This point here is where the rate of transmission outside China became much more important. Okay? So this is where we saw countries like Italy, Iran, South Korea, Japan having more and more cases. Okay? But the bulk of the disease as of now was still China. Okay? This will change. It is changing right now. Okay? So if you look at the cases in China and the cases around the world, it's picking up. And look that it's not quite the same way that it looks, right? It looks more like it's like this. So it looks more linear than just one spike. We don't know, okay? But the fact that it's linear like that may mean that we're going to be friends with COVID-19 for a little while, okay? That does not mean there's going to be active transmission, but it will be in circulation. And we'll talk about that a bit later. So people are saying, wow, China was pretty fast here, and they have a test already and all that. Well, they unfortunately had experience. So they had SARS back in 2002, and the SARS, from the first case to containment worldwide, was about 8 months or so, but it was 9,000 cases. Okay, now we're talking 120 as of today, 1,000. So, but it's impressive, from disease to testing and China containment within a month or two. So they really responded well to what they had, okay? Okay. There's also studies already, so if you actually look at New England and JAMA, okay, these are the two main ones that you will find already published studies, and that's impressive to actually have published that already. Okay, so one is in February 24th. There's another one in February, I can't remember, 20th. And we'll go over them. Okay, but the first one really was in JAMA, where they looked. It was all in China at 72,000 cases, and 62% of them were confirmed. Okay, now the next slide is important. Okay. So if you're already sleeping, just wake up, all right? Okay, this slide tells you what COVID-19 is, okay? It tells you the age distribution of the people infected. So 30 to 79 and 87% of the time. It tells you the spectrum of disease, and now on this graph, that's extremely, on this slide, that's very important. See mild there? 81% of the time. This is key here to remember Bob. 81% of the cases are mild. You're going to have a cold. Okay? And you're going to tell me, well, yeah, but it's also severe. No. I know. I see the same thing, 14%. I got it. Okay? And I see critical at 5%. Right? The severe and the critical, if you look at the case fatality rate, overall, 2.3%. And these numbers have varied throughout the last couple of months, but really between 2 and 3% is what you have to have in mind when you educate and counsel patients. Okay? If they're older than 80, then that becomes pretty significant because they have more pulmonary disease and more cardiovascular disease in general. Diabetes is another risk factor that's been identified. But really, they can progress to severe pneumonia, ARDS, so on and so forth. Okay? All right. If you are critical, that means you're in the ICU too, the whole 9 yards, on suppressors and all that. Your fatality rate is high. But you're part of the 5%. Flu is the same way, I'm just saying. Okay, so we'll talk about that also. Okay? So, healthcare personnel, because that's a question that we're going to have, right? And it's right that we have that. It's a little higher, right? But it's not 50%. Okay? So if we we take care of those patients appropriately. Okay, the case fatality rate is 3.8%. Okay? Now, there's a little bit more the severe and critical because we're very close to our patients. And remember, this was a study in China when they were right in the middle of all this. So they didn't have the education piece that we have. Okay? So they didn't physically protect themselves, okay, as they should. Healthcare professional death was 5, not percent, 5. Okay? I know you guys want to have that answer. Okay? So, okay, more data, and that's at the NHAM, and they actually they really studied the confirmed cases between December 11 and the end of January. They turned around and published that in about a month. And they have much less number of patients because they have to go through all these charts and dig and all that. And that mobilized quite a lot of manpower in 5 different sites all across China, not only in Wuhan or Hubei province. 44%, so about half were from Wuhan. Then about 26%, so about 4% had no contact with Wuhan, so no contact with the index place or the epicenter, okay? Median age was 47 years old, 42% were female, 0.9% age were, 0.9% of patients were very young, okay? So, well, I should say very young, but young, less than 15. So that's another question I get a lot. You know, how many are really young children or teenagers that are really infected by that? The reason people are asking is that the last H1N1, that was a big pool of our patients. In COVID-19, it is not. And we can speculate about that, and I'll get to it a little bit later about the transmission, but we do not have, this is not a pediatric disease, okay? Healthcare worker, again, 3.5%. Okay, so the same study, the incubation period, so 4 days. So first contact, first symptom, 40, that's median, right? It ranged, but that's the median, okay? So, or medium, sorry, all right? Fever is the most consistent feature. So, not early illness, but later on when they get more lower respiratory tract disease, it's present at 88%. So this is a key here, okay? Fever is a very important part of the presentation. Cough is also extremely important in about 2/3. Now, GI symptoms compared to H1N1, no, not much. Okay, so the nausea, the vomiting, that's upper and lower. Nausea, vomiting, diarrhea, not so much. Okay, coexisting illness, very important, especially diabetes, pulmonary disease, and cardiovascular disease. Severe illness was seen about 16%, so it's the same number roughly. And they tend to be older and tend to have more morbidity and same exposure risk. So really for clinicians here, the hints are lymphocytopenia, thrombocytopenia. They will have 86% of the time chest X-ray or CT abnormalities. Okay, they will. And most of it, or half of it, will be gram-class or atypical type viral pneumonia appearance, okay, which is consistent with viral infections. Outcome, 5% went in the ICU, 2% about mechanical ventilation. Overall death was 1.4%, and they were in the hospital for 12 days. Okay, so you have to know that data when you talk to patients and you talk to family or you talk to media. Okay, all right. So this is a breakdown. This is a takeaway directly from that particular article, and I want to show the attention here between non-severe and severe infection. And there's different complications. Septic shock, ARDS, DIC, so on and so forth. What did they use as far as treatment, and other complication things, CDDHD, ECMO, etc., etc., etc. Okay? So the severe one, that was about 15% of the presentation. Okay? Really, all of these things happen much more frequently than the non-severe. That's expected. They have severe disease, they're going to have much more complications. Remember, the severe the disease, the more severe, the older the patient, the more comorbidity they have. Okay? So if we deal with for age adult 30 to 79, not everybody will have severe disease. Okay? In fact, a few percentages. That is a key for COVID-19. Okay? What about household transmission? Right, that's the hot topic, especially in St. Louis, right? So, and we'll talk about that a little bit, all right? So what about when they did it in China? Okay. Well, they studied it, and they found out that the human to human really largely occurred in families. Close contact. Close contact is 6 feet. Okay? It is not, I am in the same building as somebody with COVID-19. Okay? That will become important on our strategies to deal with those patients. Okay? Close contact. All right? And it's ongoing, but there's prelim data. They found out there was 344 clusters and 1,300 cases in different provinces. So most clusters are pretty families. We're talking, look at this, more than two-thirds of clusters were within families. It's somewhat intuitive. So that means that when we talk about strategies in society, we have to think about that, okay? Now, what we call the secondary attack rate, which means that the transmission really of the one that got primarily infected and it was in surroundings with others, 3 to 10%. So when you have contact with somebody that has COVID-19, at least in China, you don't have a 100% chance of having COVID-19. You will have 3 to 10%. In China, I'll tell you in the US, it's much lower than that. It's already been studied out there. Although the data is limited here because we don't have any research. Okay? So, what happened outside China? Whoa! Okay? You're gonna say, whoa, that graph is like impressive, right? Okay, look at the time here. Obviously that happened after China, right? Because some of the time you can't see. But look at the number of cases also, right? So we're not talking millions here, we're not talking 10,000s. Okay, this is broken down, in different parts. So Western Pacific, the big one here in Europe, and so on and so forth. The Americas is that tiny yellow one. Just pointing that out, okay? Because that's important in the big scheme of things, okay? All right, but there's no phase coming down, right? That's because that's where we are, okay? So we're in the up phase, possibly plateauing outside of China. The dark one is really where there's COVID-19 around the world. Oh, whoa, it's like everywhere, right? Well, not everywhere is the same, okay? So, and the bigger the red dot, the more cases you have. But look at the dots, right? They're not the same everywhere. Obviously, they're big in China, right? And other places like in Iraq. This is, really here, Europe. There's a reason we'll talk about the last advisory, right? But the United States, it's not a dot, but it's not big, right? So this is also important to figure out. This is about for 2 days ago, okay? So there was actually just one that came out this morning, but it did not copy the record. It's okay. It's really to illustrate that we still have mainly issues in, as far as the worldwide number of cases. China is still number one, but really there's a lot of recovered patients that nobody talks about, by the way. 61,000 for sure are recovered, okay? This is why their curve is going down. Italy is still going strong, unfortunately. I suspect they will go down with their complete shutdown as of Monday. And Iran, South Korea. So the United States has moved up. There's now 1,300 cases this morning. And there's new cases, but there's no severe cases. There has been some death associated, but mostly are imported from other places, okay? So this is a tribal advisory, and I'm telling you how things change quickly, okay? This was a tribal advisory this morning, okay? But we all know what President Trump talked about yesterday, and so that's completely outdated. Completely, okay? So, right here should say almost all European countries. Most. Most, that's how they worded it. Most European countries. I think the UK is stricter. I don't know what okay, so, but the rest is quite the same. So that means that when you're a level 3, for example, it's 3 levels, level 1, 2, or 3. When you're a level 3, you should avoid those places. Okay, so so if people are asking me, should I travel? Obviously the first thing I'm going to say is where are you going to travel? And if they say, I want to go to Italy, for example, I'm going to say, not a good idea. Okay, so and it's really advised against. If you have a level 2, you have to be very using enhanced precautions. Okay. Not much going on in the United States internally. Okay, and I know people are going to talk, what about in Washington State? Yeah, there is some tribal advisory for that to use more precautions because there's active transmission. The key is not to go where places there's active transmission. So because we have 1 case in St. Louis does not mean active transmission. Okay, so it's okay. All right. So people that want to go to places that there is active transmission, there might be consequences on the way back. And the way back would be to be quarantined, okay? Even if you're asymptomatic, all right? So think about it, okay? There's a lot of things on the news about canceling everything. And we'll talk a little bit about that too. But right now, as far as travel is concerned, these are the places. What about the US? That's also been published March 5th. And they published basically the first case that was somebody from Wuhan, China. Okay? So 35 goes to the urgent care, has fever or cough. And he says, oh, by the way, I just was to Wuhan, visiting a family. And I went to the same seafood market, okay? So obviously, they were, they were awake wherever he went, okay? And they said, ooh, that's not good, okay? So we hear about those buzzwords, and let's make sure that you don't have COVID-19, okay? But he looks healthy, he's afebrile. He does have some bronchitis, X-ray's fine, and his respiratory panel is negative, but they involved the local health department, okay? And I don't know how they made it work in Washington, but within 1 day, they got the results. It's impressive, okay? And it was positive, okay? So he was positive and he was put on airborne isolation in the hospital. And basically, the NEJM article goes over his illness. So we had lots of fever, he had lots of cough, not much GI symptoms. His X-ray was normal on admission, as mentioned before. And they go over all his white count and all that stuff. And even, I thought about the residents about this one. Oh, where is it? You guys' favorite? Where is it? Where's the broke out? Yeah, I did. And guess what? They tested it again and again and again, just to make sure. Okay? So, and it was negative. Okay. Woohoo! Okay, so, all right. And let me tell you why they tested the broke out, right? Because on day 5, 6, he got sicker. And his X-ray now had pneumonia. And he was on vancomycin. I'm not making this up. He was on vancomycin. And as any residency program would do, they repeat the broke out 5 times, just to make sure. Okay? But that was his X-ray. Okay? Now, interestingly enough, and I'm not sure I understand it was not very well mentioned, this guy got a drug. He got a drug for compassionate use. This is a drug that has in vitro susceptibility against MERS and against SARS. This is very interesting. So, because that's going to be part of what we're going to think about treatment and whatnot, right? But compassionate use, that was on day 6 or 7. And of course, the guy gets better, okay? But they actually did well. They tested his nasopharyngeal swab and oropharyngeal swab and even his stool shedding to see if he was continuously shedding, okay? And he really stopped shedding at day 12, okay? We don't have the young because this is when he was discharged, and he was discharged home, even if he was positive, and to be not in isolation at home, because he did really well. So the question is, did he do well because of time, and he's a young guy with no disease process, or because he received that new drug? This has already come up as a question for me. I don't know the answer to that. There's another drug, an HIV drug, that has some in vitro activity. So loperamide, ritonavir, Kaletra has activity in vitro against COVID-19, but we don't know if we're going to use it or not. All right. So this is in the US now, okay? So we're having this case, and whoops, cases are starting to pop up, right? The same kind of curve. Look at the number of cases. Okay, so a curve can look great, right? It looks like the China curve, it looks like the European curve, or the worldwide curve, but always pay attention to the y-axis, okay? Okay, this is the states that have reported COVID-19, okay? Right? California, Washington, okay? Right? New York. We did report one, right? We all know it. Okay, so we reported one so far. Okay? So, because they reach a certain number, it's hard to see if they have active transmission in Washington State and California. So, this is why people are more reluctant to travel to those places. Okay, this was actually 2 days ago, believe it or not. Okay, it has changed quite a bit. Early this morning, it also changed. 2 days ago, we were about, 3 days ago, we were about 600. We're about at 1,300. Okay, so, and we're the same total death, about 25 or so. Okay. Look at the numbers. Okay, just pay attention to those numbers. Okay, and they're mostly travel related, but we know that there's person to person, and we know that there's a ton under investigation. Why is that? Because when cases start to pop everywhere, people start testing. Okay, and we're going to have more and more and more of these different types of scenarios. You know, when you think you hear them all, the next day is another scenario. Okay, so that's going to be the way the curve is going to go. We're basically in the upright part of the curve. So when people are asking me, do you know what's going to happen? It's like going on a hill upward and you don't know when you're going to go down. So the answer is, I don't know. There's models that can predict, but I'm not an epidemiologist, okay? But it predicts that we're going to have significant number of cases. That does not mean that we're going to have an outpouring of patients dying in our ICU, okay? It's the same percentage. Okay, so we know that 80% are mild cases. Okay, all right. So we all know what happened in St. Louis. I'm not going to go over who knows that person, and, you know. There's two ways that we can stop progression of disease when it comes to communicable diseases with an outbreak: isolation and quarantine. So isolation is when we separate the sick and the non-sick. So we do that in the hospitals. Right? Quarantine is basically when you've been exposed, and we don't know if you're going to have the disease or not at some point, but we basically limit your movement so that you don't move from one place and we look at you for a certain number of time. Here it's 2 weeks because we know that most people shed for 2 weeks. Okay? So this is the point. This is what, you know, the alleged that the family, the father of that family did not do. So he had a case, right? His daughter was coming from Italy, and his younger daughter wanted to go to the dance, and they decided to go, knowing they were on quarantine. Now, if you actually look at the CDC, the state, it varies from state to state. The actual response to the family should be. But there is language in there where if you're on quarantine and it's forced, you have to respect that quarantine. There's language in there that could be, if you don't, a misdemeanor. CDC also, as a federal agency, can control in and out where you're going in the country and whatnot. That's on their website. We're not there yet, but the same thing happened in the ship, right, in Japan. So they were placed on quarantine. Okay, so, and we'll talk about the data a little bit. Now, based on what we know now, remember that I told you the attack rate, the second-year attack rate in China was 3 to 10%. Here, it's 0.45%. So it's all about how you do quarantine and how you isolate yourself. Okay, so it's all about hand washing, coughing etiquette. It's all about that. When you're sick, stay home. Okay, not stay home and decide if you're sick or not. When you're sick, stay home. Because we're going to face that a lot. I'm just going to tell you. We're going to face that a lot, right? Okay. So, because that's coming, right? It's already here. Okay. But the second attack rate, 0.45%, right? Of what we know right now, where we are in the curve right now. Okay. Asymptomatic transmission. Does that happen? Yes or no? Do we know? What do you guys think? Yes. Okay. Never mind then. Yes. The answer is yes. Okay. So and that's actually been published. Okay. Also in NEJM just last week, where two were at a conference and one got symptoms because of the index patient 1, and patient 2 as well. But patient 3 and 4, which have any connection with patient 1 when he's asymptomatic, also develop symptoms. Is it a cause relation? We don't know. Maybe they would have been in contact with somebody else. Okay? But there is potential risk of transmission when you're asymptomatic. Now, this is a no man's land, okay? We don't know this. We think this is happening, but there's a reason why you don't have symptoms. And the reason you don't have symptoms is you're healthy, your immune system's containing the virus, and you don't shed it as much. Okay? That's the key right there. Okay? And when we do those PCRs, we don't quantify them. It's qualitative. So we just know if the virus is there or not. So the theory, or behind all this, is that when you're young and healthy, you're asymptomatic, but you can still shed the virus. Now the question is, do you shed enough to transmit to a lot of people? When you are sick with cough and fever, you shed quite a lot for the first 48 hours. Just like flu. It's the same thing. Okay? The ship. They swabbed pretty much everybody away. Half of them had no symptoms. They were positive. Okay? Does that mean they transmitted? Okay? We don't know the answer to that. Okay? I can tell you honestly, I think people are transmitting when they're asymptomatic, but I don't think they're transmitting at the same rate. And if you think that it's a 0.45% rate when you have disease, imagine if you're asymptomatic. It could be, 1 out of 20,000. Okay? All right. They also studied, that's in China. They also studied 24 patients that were asymptomatic. That's a very low number. And believe it or not, even if they were asymptomatic, 50% of them had an abnormal CAT scan. All right. So, and one thing that they found in that one, that particular article, is that the transmission was up to 21 days. Okay? So not the 14 that we talked about. That did not make much headway. Okay, case definition. So, as a provider, you have to know which patient you're going to test. Fever plus cough or shortness of breath, close contact to confirm the case within the 14 days of symptom onset, or travel to areas of sustained transmission within 14 days, or severe pneumonia with ARDS and we don't have a source. Okay? These are the patient under investigation that the criteria would be accepted. Okay? The reason we are doing that is that everyone wants to be tested. We saw that in our own medicine clinic, right? Was it Tuesday? People were coming like, I don't want to know if I have coronavirus or not, but I don't have any symptoms. Okay? Well, we're not at the point yet where we have to test everybody to know, because quite frankly, we have to think about the resources we have, the expenditure that's going to cost, is it worth it or not? And I'm not here for pros and cons debate, I'm just saying, okay? We have to think about those things. So testing workflow, if you have a clinical suspicion in a hospital, you isolate them, airborne isolation, we'll talk about that. You obviously notify infection prevention, and I'm extremely happy to help you. Then the State Department, basically, as of now, decides who gets tested or not. So it's not up to you. Okay? So you have a patient, you think they could be, there's a process in place where they fill out the case and they decide yay or nay. Okay, it's based through the State Health Department, CDC. Then we swab, there's a special test for COVID-19. And you can include the respiratory panel as well. And then it goes to our central location, and it's picked up by state. And we are told that the turnaround is 24 hours. By experience, when we had a PUI patient about 3 weeks ago, it took about 3.5 days. Okay? And then you decide on a case-by-case, when should we discontinue isolation? I can tell you that for most viruses, it's after illness has subsided in 7 days, or for influenza, from 5 days of time. There's even a YouTube video on how to test and package it and send it to the State Department. Okay, this is a big one, okay? So, it's a big one because it's very confusing. And it's confusing because there's mixed messages in the world, okay? So, most viruses are droplets. Take yellow mask. Close the door, take yellow mask. Okay, fine. When H1N1 came in 2019, WHO said, it's a virus, put a yellow mask. But the CDC said, wait a minute, we don't know if that virus is bad, let's put it on airborne isolation. Their CDC is doing the exact same strategy with COVID-19. WHO says, droplet is fine, yellow mask is fine, we're all good. CDC says airborne. Airborne means the ducky mask, the N95, okay? Does not mean the PAPR, okay? Does not mean the alien suit, okay? So that's a problem because that means everybody has to be tested. I'm sorry, tested. Have to be fit tested. Thank you. Fit tested for the mask. And if you have facial hair, gentlemen, I don't want to say ladies. Gentlemen, that's a problem because we cannot be tested. Cannot be fit tested. Okay. There's going to be discussion around that a lot because at some point, when we announce that there's a potential case in the emergency room and everybody runs and grabs a mask, even if they have not even laid eyes 1 mile away to the patient, then we run out of masks. It's the reality. So the CDC has clear guidelines now, as of yesterday. If you run out of N95 masks or respirator mask, as they say, then it's okay to put the yellow mask. Except if you do procedures that will aerosolize the thing, so intubation, bronchoscopy, stuff like that. Okay? So this is because we're going to run out. If you see pictures, unfortunately, people wear 10 masks at a time, and our visitors, we've seen them come and grab like a box, that kind of thing. So right now it's airborne. So airborne means the ducky mask, okay, the goggles, the contact tube, okay, or the face shield or the goggles. Okay? So, all right, there's even CDC guidelines for donning and doffing. If you were not here, what was it, 4 years ago, where we had to do all this fun stuff? Okay, so yeah, please refer to that. Okay. There's also employee health, where there's a link on the internet about exposure and whatnot, what to do in those cases. All right. So we have to remember a couple of things. Okay. H1N1 back in 2019. Okay. This is how many cases we have. This is how many people were hospitalized. This is how many people died. Remember that y-axis? 25, 30, 50. H1N1 in 2009. That same H1N1 is in circulation today. In fact, it's the most common influenza A isolated this season, and it's in your vaccine. Do not forget about the flu. That's the message of this. And remember, I said the mortality rate of coronavirus was 2 to 3%, right? Well, here where the numbers get very interesting that they have to analyze. You go calculate those numbers, 2009. The mortality was 0.02%. But it was everywhere. Okay? Now we have a virus that is not everywhere, that has more mortality. In 1818, Spanish flu, right? And that's just to put things in perspective. A third of the world population was infected. That's impressive. It actually killed more people than World War I. They were young individuals that died. Young soldiers. In fact, that's how they first saw with soldiers. Okay? 50 million people died for a while. And remember that the world population was much less. Almost 700,000 Americans died in Spanish flu. Okay? Remember the y-axis of the coronavirus. Right? So that put things in perspective. Okay? That means that yes, we have to study the virus. Yes, we have to educate ourselves. Yes, we have to be prepared. Hand wash it. Don't cough on somebody. When you take care of patients that may have an influenza-like illness, you can wear a yellow mask. Okay? These are the types. And when that mask is warm, when you're done with the patient, you don't put the mask back in your pocket and it's good for the day. Okay? Outside here, it's contaminated, right? So all these things people have to remember. These are so simple steps, right? But people have to remember that, right? So it's too bad it didn't come, but right now with the flu, right now it's kind of 50-50, A and B. A is H1N1 by far. This year, the same strain as 2009. Anybody want to guess how many influenza cases to this day, this season, we have in the state of Missouri? Anybody wants to guess how many? The state of Missouri, how many flu cases since the beginning of the season?
5,000.
I have 5,000. Who says more? Who says less?
67,000.
Okay. Anybody else? Well, you know what's very interesting? How many people in China have coronavirus? How many people did I say? 80,000, right? In the state of Missouri, as of today, there has been 80,000 influenza patients. Okay. Okay, good. This is why it's important to put it in perspective, okay? Why are we not hearing about it? Every year, there's an expected pneumonia with influenza rate. Every year. And some years, like 2 years ago, we really went above that. That's why it was a bad flu season, okay? This year, we have not crossed the epidemic threshold. So people are not talking about it. But it's the same number in the state of Missouri of influenza case that in the whole China with coronavirus. Think about it. And we have Asymptomatic, which has zero resistance so far this year. Okay? So just think about this. Okay? And conclusions? Transmitted by droplet and contact on infected spaces. Causes mild disease, 80%. Mortality overall is 2 to 3. Much more when you have severe disease and ICU mechanical ventilation in the living. Older age, diabetic, pulmonary, cardiovascular disease are important risk factors with severe infection. Testing is only through the state. That will likely change. Okay, it will change. Okay, there's talks within the St. Louis region about a different plan. Okay. Treatment is supported. Preventive measures are key for stopping transmission. The most important thing about the conclusions for today, remember Bob, be like Bob. Thank